X-ray has got poor sensitivity early in the disease and can be normal in patients with COVID-19. A normal chest radiograph, it does not exclude COVID-19 pneumonia. So if a patient has a normal chest X-ray, then that does not mean that the person is not having COVID-19. Chest X-ray can be used for assessing the disease progression or severity, and it's mostly used for the follow-up. So there are various patterns on the chest X-ray. The most important patterns are the bilateral consolidation as well as the ground glass opacities. I'll be showing a number of images later, and the distribution should be peripheral and predominantly in the lower lobe. No single feature of COVID-19 pneumonia on a chest radiograph is specific or diagnostic, but a combination of multifocal peripheral lung changes of ground glass opacity and consolidation, which are most commonly bilateral, may be present. So we now move on to the various patterns on the chest X-ray. So the first thing is the reverse batwing appearance. This is the first image. So what we are seeing on the periphery, there is opacity in bilateral lungs. So this means that the consolidation has occurred, and it is usually sparing the perihilar region. So the consolidation is in the periphery, but the perihilar region is not involved. So this is called as the reverse batwing appearance. And the next most common thing is the consolidation. So consolidation, where do we look? We look it in the lower lobes of the lung, such as in this particular image where we see lower lobe predominant consolidation. And it can also occur in the peribronchial region, as in this case, and it can be multifocal. So in this particular chest radiograph, what we are seeing is there's a well-defined rounded opacity in the right upper zone without any calcifications and without any other abnormalities. So this particular thing is called as a ball pattern or round pneumonia, and it can also be bilaterally symmetrical. Diffuse lung involvement of ground glass opacities and consolidation may also be seen. So a study was conducted in Hong Kong of 64 patients who were hospitalized with COVID-19 infections. Out of these, 35% of the patients, they had radiographically normal chest X-ray, and later they have developed the abnormalities. So the study suggested that the chest radiographic findings were typically seen on days 10 to 12 after the symptom onset, and it was given by the Fleshner Society for Thoracic Radiology. So now we have various scoring systems. We have a scoring system in CT, ultrasound, and chest X-ray also. So what we usually do is we take a chest X-ray and we draw two horizontal lines. So this is the aortic knuckle or the aortic arch. So inferior to the aortic arch, what we do is we draw a horizontal line, which is called as the line A. And below the hilum, we draw a second line, which is called as the line B. So this divides the chest X-ray into 6 particular zones, zone A to zone F. So now for each zone, we are going to give a score of 1, that is a total score of 6, and we'll see the involvement. For example, in this particular image, these two zones are involved. So we calculate it as 1 plus 1, that is 2. And in this particular image, there are 4 zones which are involved. So 2 plus 2, we give it as 4. So what is the clinical importance for the scoring? If at least 2 zones of the lungs are involved, then the patient is likely to get admitted in the hospital, and 3 or more than 3 lung zones are involved, then the patient is likely to go for intubation. That completes the chest X-ray. Now we move on to the CT findings. So the first thing is, it is not recommended for the screening purpose. So, and in suspected cases, also it's not recommended except in RT-PCR negative cases and the person who is having a strong history, that is a contact with COVID-19 positive case and is having clinical deterioration. We can do if it is a proven case, that also sparingly, and it is also reserved for hospitalized symptomatic patients with specific clinical indication for CT, like in these conditions. The main important point what we need to remember is it should not be used for a screening purpose, and it is not the first line test to diagnose the COVID-19 pneumonia. The present justification for CT is in areas with insufficient RT-PCR and immunoassays or with high prevalence of COVID-19, CT can be considered as a diagnostic method. Only in this particular case, we can use it as a diagnostic method and not regularly. So here are the various imaging findings. The first thing is ground glass opacity. So what's a ground glass opacity? It's a haziness in the lung field which appears like this. And the second thing is called crazy pavement pattern. So what's the difference between this ground glass opacity and crazy pavement pattern? Both are the same, but what we see are the septal thickening in between the ground glass opacity, and it is as if some rocks are placed, a small square bricks are placed in between the ground glass opacity. So this is called as a crazy paving appearance. Normally it is seen in pulmonary alveolar proteinosis, where the alveoli are filled with proteins that give rise to the ground glass appearance. And the third thing is the consolidation. What's the difference between ground glass opacity and consolidation? Ground glass opacity is where through the haziness we can see the underlying vessels like this, and through the consolidation we can't see the underlying vessels and the bronchus. Now we have something called as the halo sign and the reverse halo sign. Reverse halo sign is what we see in COVID-19 pneumonia. And so first let's see what is halo sign. Halo sign is nothing but it's a zone of consolidation which is surrounded by ground glass in the periphery. So reverse ground glass is exactly opposite to that, where in the center we have ground glass and it is surrounded by consolidation at the periphery. So this reverse ground glass is also called as the Étoile sign. And here what we are seeing is we are seeing the opacity. We can tell it as a crazy pavement appearance because we are seeing ground glass with the septal thickening in between, and we can see these white color structures. These are nothing but the vessels. So these vessels, they are prominent. That's why they are called as the proximal dilator vessel sign. And here what we are seeing is the intralesional dilator vessels, where we call it as the microvascular dilatation sign. In this particular image, what we are seeing is there's an opacity, and inside that opacity, we are seeing a hypodense area inside. So this is called as the vacuole sign. Here in this particular image, what we are seeing is parallel to the pleura, we are seeing a white line, and which is not extending beyond, it's only here. So this is called as the pleural line sign. And in this particular image, what we are seeing is a triangular opacity, which is like a net. This is called as the spider net sign. So here are the various findings what we see in COVID-19, the typical and atypical findings. We'll start with the atypical findings. See, what we don't find is we don't find lymphadenopathy. We don't find cavitation and calcification like what we see in tuberculosis. We don't see tree in bud pattern, nodular pattern, mass, pleural thickening, or pleural effusion. Pleural effusion can occur as a complication, but it's not regularly seen. So what are the typical findings? Typical findings means they suggest that there is COVID. So what are the findings? There are various ground glass opacities. Then next we need to see where the location is, whether it's in the periphery or in the center. So mostly it should be in the periphery with a basal distribution. And we have to check for the crazy paving pattern. We have to check for the reverse halo sign and the spider web sign, what I showed you earlier. So there is a classification which has emerged from Netherlands, which is given by the Dutch Group of Radiological Society, and the full form is COVID-19 Reporting and Data System. So what is this? This CORADS classification is just like our BIRADS, TIRADS, and LIRADS, what we use for other organ systems, and it doesn't tell about the severity of the disease. It only tells about the level of suspicion for pulmonary involvement. So where do we see this CORADS? Do we see it on X-ray, or do we see it on CT or ultrasound? It is only when we see that on a non-contrast CT and not a contrast CT. Suppose if we do a contrast CT, it may hinder the interpretation for the ground glass opacities. So a non-contrast CT is done, and then we proceed on to the CORADS classification. So now we have the 0 to 6. So the most important things are 1 and 6. 1 is a completely normal CT. Okay, if there are no findings, then we give it as CORADS category 1. Then what is 6? 6 is a proven case. It is a RT-PCR positive for SARS-CoV-2. Just like our BIRADS, where it is histopathologically proven, we have COVID CORADS 6, which is RT-PCR positive. So what is 0? 0 is not interpretable. That means suppose if a patient has come for a CT scan and he keeps on coughing and he is unable to hold his breath, then that means the study is incomplete and we are not able to assign a particular CORADS category for him. So CORADS 1, like I said, it is completely normal or non-infectious. CORADS 2, the level of suspicion is low. That is, there may be findings like tree in bud, as I told earlier, but the typical whatever the futures what we see, they are not for COVID-19. CORADS 3, the radiologist is unsure whether that particular findings are for COVID or not COVID. You can also see in him influenza cases. CORADS 4 and 5, the suspicion levels are high and very high. So what's the difference between CORADS 4 and CORADS 5? CORADS 5, we see multifocal ground glass opacities, predominantly in the basal regions subplurally. CORADS 4, you can have unifocal ground glass opacities. They may not be subpleural, but they can be also in the center. So if it's a unifocal, we can go for CORADS 4. And if they are multifocal involving the bilateral lungs in the subpleural region, we can go for CORADS 5. So I'll quickly pass through the slides. CORADS 0, as I have already said, it is chosen if none of the 5 categories can be assigned because scans are incomplete or of insufficient quality. For example, because of severe artifacts due to coughing or breathing. We move on to CORADS 1. CORADS 1 is a completely normal chest CT. These are findings that indicate a non-infectious disease like congestive heart failure, sarcoidosis, histoplasmosis, malignancies, usual interstitial pneumonia, or fibrotic non-specific interstitial pneumonitis. But there's an exception. It has to mate for the first few days of a mild infection where the CT can be normal. For example, in this particular image, what we are seeing is axial section in the lung window CT image where we do not find any typical features of COVID-19. Those are the ground glass opacities. We neither see any consolidation or any subpleural bands and nothing. So this is a completely normal chest CT, which we can give it as CORADS 1, which is completely normal. CORADS 2, the level of COVID-19 infection is low. The findings are consistent with other infections like bronchiolitis. So obviously no typical signs of COVID-19 are seen. For example, in this particular image, we can see the tree bud pattern and we can see areas of consolidation, but we do not see any ground glass opacities. So this can be CORADS 2. CORADS 3, as I already said, that the radiologist is completely unsure whether to give that as CORADS or not. So the other abnormalities indicating the infection are central or multifocal consolidation with the surrounding ground glass opacities, unifocal ground glass opacity, widespread bronchopneumonia, lobar pneumonia, and septic emboli. For example, these are the 4 various cases where we have unifocal ground glass opacity in various locations. So these are the same images where the unifocal areas, there are multifocal areas of consolidation where the PCR was negative. This particular, the 6th case, it was positive for the Haemophilus influenza case. So CORADS 4, the suspicion level is high. Mostly these are suspicious CT findings, but they are not extremely typical. Typical are what I have said for like the bilateral subpleural involvement of the ground glass. So these are usually unilateral ground glass area or a patch. The findings suspicious of COVID-19 in underlying pulmonary disease. So it's like this, where we have a unilateral areas of ground glass opacity in the left upper lobe. CORADS 5 is typical, where there are multifocal ground glass opacities and consolidation. They have to be bilateral, they have to be vascular thickening, subpleural bands, crazy paving pattern, and the reverse halo sign. So what we see here are the multifocal areas of ground glass opacities and consolidation in the various parts of the lung. CORADS 6, as I already told, it's an RT-PCR proven case of COVID. We now have a CT severity score, just like what I have told for the X-ray. We have a CT severity score. It's a method used to identify the severe forms of COVID-19. It provides an approach to rapidly identify patients who need hospitalization. So CT severity score is used to quickly and objectively evaluate the severity of lung involvement. So we all know there are 2 lungs. These 2 lungs, they are divided into 5 lobes. On the right, there are 3 lobes, and the left, there are 2 lobes, which are divided by the major and the minor fissures. So for each lobe, we are going to give a score of 5. So all the 5 into 5, we are going to give a total score of 25. So we have to see how much each lobe has been involved. For example, if 5% of the lobe is involved, we give a score of 1. If 5 to 25% is involved, we give a score of 2. 25 to 50% if it's infected, then we give a score of 3. 50 to 75% if it's infected, we give a score of 4. And if it is more than 75%, we give a score of 5. So then we add on all the scores, and the maximum score for all the 5 lobes is 25. And then the total score, if it is less than 8, then it is called as a mild variety. If it is 9 to 15, it's called as a moderate variety. And more than 15, we call it as a severe case. So this is the summary. The first thing what we need to do is we need to check out the complaints. We need to have the history, since how many days the patient is having the symptoms. Then we need to go for the various CT findings. As I already told, the ground glass opacity is predominantly in the lower areas, and usually it should be peripheral. And is there any consolidation on all those things? Then we have to go for the crazy paving if they are appearing, the reversed halo sign, spider web sign, vascular thickening, pleural fluid and lymphadenopathy are atypical findings of COVID-19. And then we are going to see the score. We then progress to CORADS, which determines the level of suspicion. Then this I've added in the last minute. We also have few ultrasound findings which suggest COVID. So in a normal ultrasound of the lung, what we find, this is the pleural line, the first one, and these are the horizontal lines which are called as the A lines. A lines are the normal lines what we generally see. Suppose if there are any pathology which is happening in the lung, like consolidation or any other thing, then we see these vertical lines. These vertical lines are called as the B lines. B lines are the abnormal lines. So what are the advantages of the lung ultrasound? So it's non-invasive, there is no radiation, it's easily available, it's bedside, and can diagnose pleural effusion, pneumothorax, and consolidation. And what are the various disadvantages? It's operator dependent. It depends upon the amount of knowledge the operator is having in diagnosis. And it's not a continuous monitoring modality just like the ECG. For example, this is a normal chest CT what we are looking at. So we have the A lines which we normally see. And this particular image, there are few ground glass opacities noted in the peripheral regions, and we see a few B lines if you can appreciate. And here we have the lung which is fully consolidated in the bilateral fields. So what we see here is a hypoechoic region. So similar to the X-ray and similar to the CT, we also have a scoring system in the ultrasound from a score of 0 to a score of 3. So score 0 means there will be predominantly A lines or less than 3 separated B lines. Score of 1, there should at least be 3 B lines or coalescent lines occupying less than 50% of the screen without a clearly irregular pleural line. Score of 2, the coalescent B lines occupying more than 50% of the screen without a clearly irregular pleural line. Score of 3 suggests that there are larger consolidations, at least more than 1 centimeter, and it is useful to characterize the consolidation, which appears hypoechoic. That's it. Thank you. That's my last slide.